group for evaluating the cardiovascular risk in patients with diabetes. Jerome Bax, some of you may know him, was the first author of this report, advocating for the use of myocardial perfusion scintigraphy as a screening tool for patients at high risk, particularly those with diabetes. And we did this back of the envelope, literally in a cafeteria analysis, and came with the observation that if you were to test 14 million people with unconditionally treat all and subject them to a stress test, the unconditional treatment would win. It would prevent more events, 84,000 versus 67,000, at a lower cost, and therefore it would be more cost effective. And so that pretty much started our rhetorical exercise. And we were proven right a couple of years later when the DIAD study was published, showing that the treatment outcomes are not impacted by a screening strategy. And the Dynamite study, which was not completed in Europe and France, also confirmed that there was really no value to doing myocardial scintigraphy in diabetic patients. But that's besides the point. So what are the arguments for these two treatment strategies? Statins for everyone. If patients are exposed lifelong to elevated LDL or atherogenic lipoproteins. Statins work in everybody, they're cheap, they're very well tolerated, and at about a certain age, everyone is at cardiovascular disease risk. The counter argument is that perhaps we should focus on therapies in individuals who are at the highest risk. We can identify them early, treat them aggressively. And the risk factor approach has very modest discrimination, and perhaps using tools like coronary calcium perhaps may improve discrimination. And importantly, those that are not destined to have an event are unlikely to benefit from statin therapy. Therefore, you can avoid over-statinization or over-medicalization. But at the end of it, I think this argument is primarily economic and to some degree political and not scientific. The key question is, does any treatment intervention provide value? At what cost? And can be afforded? So it becomes a pharmacoeconomic or a cost-effectiveness exercise. And as such, it is anchored on a modeling exercise. And I just wanted to sort of caution you all about models, as exemplified by what George Buck said at best. Essentially, all models are wrong, but some are useful. Since all models are wrong, the scientists cannot obtain a correct one by excessive elaboration. And remember that all models are wrong. The practical question is, how wrong do they have to be to not be useful? I think if we learn from this, I think we will be better served. So what we did is we did the same back-of-the-envelope cost-effective analysis in response to the SHAPE guidelines that were published in the American Journal of Cardiology in 2006, where SHAPE was proven to be cost-effective relative to an NCEP ATP3-based strategy. And George and I thought about, well, what if we were to incorporate a treat-all, an unconditional treatment strategy, and how would it hold up? So we made some assumptions, and these assumptions are open to criticism. So we said we're going to use individuals with an FRS greater than 20. For the SHAPE strategy, the coronary calcium greater than 100. Those meeting treatment thresholds, 100% in treat-all, 30% in the NCEP, 25% in the SHAPE. The number of events, this is the Pareto's rule. 80% of the events will occur in 20% of the patients at high risk, and pretty much borne out by all the other studies. We assumed that the statin treatment effect would be a 30% relative risk reduction across the board. We did not discriminate between the intensity of therapy. At that time, the cost of coronary CT scan was about $400. NCEP we assumed was $100. The cost of statin therapy, $2 per day, came to about $720. We know now that it's much cheaper than that. And we assumed an unrealistic adherence rate of about 100%. And I've shown you what the preventing death and preventing an event translates into a life year so that we can compare apples to apples. And when we did that exercise, what we found was that unconditional treatment prevents about 150,000 events, which is twice what a ATP3 guided treatment strategy prevents. A little bit more than what a coronary calcium strategy prevents. But the cost is higher. The net cost is higher with the unconditional treatment, but it still meets the cost effectiveness threshold, which is roughly about 50,000, which is a conservative estimate. The incremental cost effectiveness ratio is shown there relative to each one. So that was our challenge to shape, is that you ought to include treat all strategy. Now that was back in 2007. Things are different. Our assumptions probably were too naive. Some would say perhaps they were misestimates. So what I've done here for the purpose of this presentation is I've taken some realistic scenario assumptions based on 2015. We're going to still use the treatment threshold of FRs greater than 20 and CMC greater than 100. We know now that about 25% of the general population has a coronary calcium level greater than 25%, and 60% of events accrue in that population. We also, and this is being somewhat anti-conservative here, I'm attributing a higher treatment effect in those that have a higher CAC of greater than 100, moderate intensity, and low to moderate intensity in the treat-all strategy. The cost that I've included here is $125. It doesn't really matter if you downgrade it to $75. It doesn't make a material difference. The cost of statin per treatment is the generic cost, $50. The cost savings is the same. 100,000 is the value in return, and then the loss of life years is pretty much the same here. When you put these variables in the calculator, what we get is 82,000 events saved for a unconditional treatment strategy, which is slightly higher than the SHAPE screening strategy, but definitely more than the ATP3-based treatment strategy. And the cost is, the gross cost is much lower than either one of the two treatment strategies. So when you look at the cost per life years per event saved, the most cost-effective treatment strategy is still the unconditional strategy, although the differences are not that great, but relatively speaking, that is the most cost-effective treatment strategy based on these assumptions. If you want to use a coronary calcium score of greater than 0, 50% prevalence, 80% of the events will occur in that. Again, you can see that the unconditional treatment strategy still wins based on this cost-effective analysis. I have the risk calculator here on my spreadsheet. You can give me any input, I could plug it in, and you will still see that this is pretty much insensitive to all those cost estimates. What it doesn't include are those sophisticated inputs like disutility from statin intolerance and the disutility related to the radiation exposure. We can add that as other tools have done it. It doesn't make much of a material difference.
Okay, can we try to throw
poke holes? Yeah, absolutely.
So, is there a consideration of compliance?
Yeah. So you notice here what I have done in the compliance rate and the assumptions. The Eisner study this morning was quoted as evidence of improved compliance with scanning group. And if you go back to the original paper, it is 86% versus 86%, no scan, scan. So Eisner group was conducted in a highly educated, very affluent, very motivated individuals where the baseline compliance rate was in excess of 80%. It's very difficult to prove that you're going to improve compliance in such a group of people. What I've done here is I've looked at the real-world statin compliance rates. 55% for the treat all and the NCEP strategy group, and 65% for the SHAPE group, which is what one study from Phil Greenland demonstrated, that there is a small but statistically significant improvement in compliance.
Is that realistic? I don't know about.
But you can't. So you're taking Eisner all of the patients,
Right,
Which is
scan
not
versus
good,
no scan.
But that's not any of your endpoints here.
Yeah, but you can use coronary calcium
No,
score
you
greater
have to
than
take time
100.
greater than 100.
Yeah, so it's 90% versus
There's a
86%.
significant difference when you separate them, even in a highly educated group. But that's not a big deal. I think that's fair to say. There'll be some statin adherence. Phil Greenland came up with a 20% advantage for calcium based on 13 trials. I don't think that's the model.
It doesn't make a difference.
No, I agree with you.
I
totally
can
agree.
input any number you want, it
Right.
does not make a material difference.
No, I agree with you. I don't think the statin adherence is going to be a big difference. I think the biggest model thing that I would suggest in your model that would need to be tweaked is the cost of statin treatment is not $50 a year in the United States, no matter where you get your drug or how you take your drug, because you forgot to model in the testing that is required, not questionable, but mandatory when you start a statin and then follow up lipid testing. And that adds significantly to the cost of statin treatment, which would absolutely completely shift everything in favor of calcium scoring.
Absolutely true, but it will not change the number of events prevented. The number of events prevented will still be
But
higher.
if cost is an endpoint and you add that much incremental cost to treatment, I do think it may shift the
We can
numbers.
do that at the...
Because I think there's probably another $50, at least in the initiation,
Right.
from blood tests for lipids and LFTs, which are mandatory, and then a follow-up lipid test, which is almost, I would say, mandatory at some point if you're putting a person on a
So
statin.
just an exercise. Right now, the gross cost is $2.5 billion for treatment.
Right.
So if you add another $50, which is double the cost, it will be still $5 billion. It will still be less than $6.875 billion. I've done all these sensitivity analyses. Yes, the cost effectiveness of coronary calcification is sensitive to the cost of the statin and the disutility of the statin, as I will show you later. So when we look at the evidence base for cost effectiveness of screening strategies in this space, there are about 8 or 9 studies. 6 of them have included treat-all strategy. And vast majority of them point out towards treat all as the winning strategy. The 2 exceptions to the rule are the Fletcher study from Phil Greenland and the Roberts study that was published in March in the PLOS. And the coronary calcium treatment strategy was dominant based on an increased statin cost and increased disutility. So my conclusion is that CAC-based strategy trumps treatment-all strategy only in scenarios with unfavorable statin assumptions, and that was reflected in the paper from Phil Greenland that is shown here. In the bottom curve, you'd say with unfavorable statin assumptions, which is about a $1 per pill, $365 for a year, and a disutility of not being willing to trade off 14 days of intolerance to statins, then clearly the coronary calcium-based treatment strategy wins. Based on a 13 cents per pill, which translates to $50 a year, and no quality of life penalty, no disutility with statin intolerance, you can see it will meet a $5,000 per quality saved willingness to pay criteria, treat-all strategy. So that's one here. The other controversy has been that the ATP4 based risk assessment will amplify patients that are eligible for statin therapy. It will increase the pool by roughly about 13 million, about 10 million of which are for primary prevention candidates, particularly in the 60 to 75 category, age category. And I like to remind you, and I think David touched upon this, is that the risk estimates patients most likely to benefit, not those who should be treated with statins. For example, in the ATP3, you have 43 million candidates who are eligible for statin therapy, but how many are actually taking statins? Only 25 million. So this tool should be used as a conversation starting intervention for risk factor modification, including treatment with the statins. So if you were to reduce your treatment threshold from 7.5%, which is currently guideline recommended, to 4%, you will expand the pool to 70 million, or even 3% will expand the pool to 77 million. Remember, this is age category 40 to 75. If you were to increase the lower limit from 40 to 50, the proportion of people who are eligible for therapy will approach 90%, which is what we are saying, treat all strategy. So shifting from a 7.5 treatment threshold to a greater than 3% treatment threshold will be estimated over a lifespan horizon to avert additional 161,000 events based on this population cohort. And there's a 93% chance, these are probabilistic sensitivity analysis, 93% chance that the optimal treatment threshold is about 5% or lower using a cost effectiveness threshold of about $100,000 per crop. So again, expanding, not shrinking the pool of individuals who are eligible for statin therapy. I think Jim already went over this. What are the 4 essential requirements of a screening tool? The test must be practical in the clinical setting. It must accurately characterize low and high risk patients, that is prognostic utility. Identification of at-risk individuals should lead to a treatment that improves outcome, that is predictive utility or clinical utility. And more importantly, the process should be cost effective. So, and if you look at these 5 biomarkers or imaging tools, CRP, yes, we have a point of care assay, but the risk prediction accuracy is weak. We don't have any outcome study, and we don't have any study proving its cost effectiveness. The myocardial perfusion imaging studies are proven not to be, to improve outcomes, and therefore they're not cost effective. But if you look at the coronary calcium screening, there's not a practical point of care assay available. The risk prediction accuracy is modest to strong, but we don't have any studies with improved outcomes, and therefore we don't have any idea whether it's going to be cost effective. So some of you may know that Johnny Carson used to invite this guy called Kreskin in the Tonight Show, and he would say that for those who believe, no explanation is necessary, and for those who don't, no explanation is possible. I think we already know who the believers and the non-believers in this room are. So I'm going to switch gears and talk a little bit about the polypill. I was asking
Okay, can we go back over this? So we didn't touch at all on the long-term side effects of statins that came to light with the diabetes and dementia and others.
That was factored in the disutility that
that's
addressed here. That was addressed in these Fletcher analysis and the PLOS analysis. That was addressed in that.
Yeah,
I think that it's important to keep in mind that at this point, I remain unconvinced that the chemical change that we're seeing induced by statins, with elevated blood sugar levels, is that truly a diabetic pathophysiologic process? Because most patients who in the Jupiter study became diabetic using whatever criteria they used, 80% of them were already pre-diabetic. They were destined to become diabetic, but these individuals also gained benefit from statin therapy. So overall, if you look at the totality of evidence, even these individuals derive benefit from statin.
And my point was not that.
Right.
We already know that,
So even if you factor in the disutility of diet, all the adverse side effects, the muscle aches, patient preferences, it's still, I mean, as I said before, that the cost effectiveness analyses are basically modeling exercises.
My point was that those disutility, particularly the public conception,
Right.
results in significantly lower adherence than what you're modeling here.
Yeah, that is absolutely right, which is why I said there's an opportunity for coronary calcium to be used as a de-risking and a de-escalating strategy rather than identifying those who are going to get benefit from it. Because there's a much bigger population of patients who are deemed to be at high risk based on traditional risk factor assessment that have a CSC of 0, and that's where the opportunity lies, because the contrast in event rates between those who are treated and not treated is huge, and that's much more feasible. I'll talk about it later on after I finish the polypal. I only have 3 slides on polypal.
Before you go, any comments on this treat all versus testing before we go to the polypal section?
Well, just if we went down to a model of CAC greater than 0, at least in MESA, which may not be the perfect cohort, 96% of all events, including strokes, were identified correctly. So with a CAC greater than 0, you would have 50% of people excluded from treatment, and you would capture 96% of events. And it would be interesting to see if the MESA study, with your assumptions, how it would have.
Well, these are from MESA. By my estimate, it was 81% of all events.
I understand that, but MESA is 96%. And there is no cohort in the world that would show 80.
No, I looked at the 7.9 median year follow-up using 353 cardiovascular disease events or 252 CHD.
Blaha just published the Power of Zero in MESA about a month ago. He reports 4% of events over 10 years have occurred, including strokes, every event you can imagine. 4% have occurred in a score of 0.
Yeah, it won't make much of a difference.
You don't think up to 96% event capture would change it?
No.
I believe it.
I can show you all of that. I've done that. I've done 100%. You're free to use it any which way you want to. You can play around with it. It doesn't make a material difference. Because the number of events prevented will be dependent on the number of people who are treated. If more people are being treated and treat all, then you're going to have greater number of events being prevented. Like, what was that guy who said that? The guy from Harvard, the epidemiologist from Harvard? I'm forgetting his name. Yeah, anyway, so it won't make any much of a difference. You're free to use it any which way you want to. All right, let's go to...
Sorry, can I one last question? Kind of combining the two things, if you looked at your approach of calcium score of 0, avoiding treatment, have you looked at the cost effectiveness?
Yeah, that's a very good point, and I'll talk about that, and we can play around with that too.
Just one other thing, and that is I didn't see the accounting for increased exercise, maybe better diet, as well as the statin treatment, the weight loss that might go along with calcium scoring in the positive group.
Yeah, well, we can. I don't know how do you quantify that?
Well, I mean, you have to kind of probably model what you think would be the effect.
Well, your model would be more than 30%, assuming other things people would do that are non-pharmacologic intervention, and those contribute to event reduction.
All good points. Somebody, did you?
I was going to say that I have trouble believing that any of those co-effects will last for 13 years. Maybe 6 months, a year, maybe.
You mean improved lifestyle?
Exercise and doing all the right things is not going to last for more than a year.
It doesn't make much of a difference.
6-year compliance data so far that shows it lasts for 6 years without further reinforcement to the patient. That's the PAC study. So you cannot believe the data, but the data is there. I'm just telling you that there's excellent data already. I don't think we want to debate the literature. We have long-term data. Compliance stays higher with a calcium score. You cannot believe it.
Translate to a lifestyle modification.
It does for 6 years. I'm just saying we have 6-year data. So it's out there for 6 years. I've published 4 papers on it for up to 4 years, and Alan Taylor published 6-year data. There's always a persistence of better lifestyle. It just exists. We don't have to believe it, but it's there.
It bears repeating. These are
That's
more
fine too.
economic and political.
We only have 4 papers. We only have 4 papers.
Science here.
Right.
So.
Well, we only have 4 papers in about 4,000 patients total, but it's not a bad cohort to start with.
Okay. So let me talk a little bit about Polypill. I was involved in the FDA deliberations on Polypill because Salim Yusuf and Dr. Wall had sort of made a pitch for the FDA to consider approving the Polypill. The FDA has not approved any Polypill. The FDA has approved combinations of antihypertensives. The FDA has not ever approved a Polypill in the concept that the Polypill is designed to be used. So I will summarize some of those observations here and give you my own opinions about the concept of the Polypill. The concept is intuitively appealing to both physicians and patients. So the modeling exercise by Salim Yusuf and Wall predicted that a 70 to 80% risk reduction in coronary heart disease and 65 to 75% risk reduction in stroke. But the impact of risk factor is modest, 7 millimeter drop in systolic blood pressure, 31 milligram drop in LDL, in short-term studies that were primarily conducted as primary prevention studies. The long-term studies, anywhere from 9 to 24 months, average of 15 months in secondary prevention or mixed cohort, yield even more modest effects on risk factors. 4 millimeter difference in systolic blood pressure and 16 milligram per deciliter difference in LDL cholesterol. Yes, the treatment adherence improves from 24 to 100%. But there's also a higher discontinuation rate due to non-serious adverse events. But what is interesting is that you would have expected the event rates, even though these studies were never powered adequately for outcome events, you would have expected the point estimate to go in the right direction. Well, there's a numerical imbalance in cardiovascular events not favoring Polypill. I'm using FDA language here, which in other words means it was going in the wrong direction. In studies that were not powered, the all-cause mortality hazard ratio was 1.26. The cardiovascular disease event rate was 1.38. So there are ongoing studies enrolling 25,000 patients, and I've highlighted 4 of the primary prevention studies that certainly inform us. And this is the paper that Huffman published in JAMA, and it doesn't show that well. But all-cause mortality hazard ratio 1.26, cardiovascular disease event rate 1.38, and the weighted mean difference in systolic blood pressure, total cholesterol, LDL cholesterol was modest.
Imbalance with excess rates.
Again, it could be a play of chance, for sure. But
people high risk to begin with, and that's
possibly,
not being fully
yes,
adjusted.
possibly, because this is a secondary prevention cohort. So here's what the evidence base is at this point. Polypill is not recommended by societal guidelines. Polypill is not even part of the World Health Organization's model list of essential medicines. The WHO has this list of essential medicines that does not require a high quality evidence, including the evidence derived from randomized controlled trials. The regulatory pathway is uncertain, but demonstrating bioequivalence and therapeutic equivalence to exclude the possibility of a pharmacokinetic or pharmacodynamic interaction might be sufficient to gain marketing approval. That's the positive news that came out of that FDA deliberation in September of 2014. That they're willing to consider approving a Polypill, and the Cardiopharma is the first U.S. company that has actually submitted the proposal to the FDA.
Cardiopharma,
I think. Real-world adherence and safety issues related to treatment discontinuation are best addressed in a phase 4 registry study post-approval. That was another consensus that came out of the meeting, that we cannot ever design a controlled trial to address adherence, and it would not be under real-world scenarios. It would be more under controlled conditions, and therefore would be not relevant to the real-world practice. That this can only be done in a phase 4 registry type of study. Overall, the current evidence is not strongly supportive of the Polypill hypothesis in secondary prevention of atherosclerotic cardiovascular disease. And finally, and this is my editorial comment, on the basis of current evidence, the high expectations generated by rosy predictions derived from past modeling exercise will need to be recalibrated. And it's always true. I mean, we always try to model in a very simplistic way. We always overestimate it. And that's one of the lessons to be learned from these modeling exercises. And so it's relevant to what Jim Min was proposing, that somehow if you can improve the relative risk reduction using a particle strategy. I haven't seen that data. We have the secondary prevention data. What we don't have is the primary prevention data that will come out of cold 3,4 tips and polyuron. But so far, the data from secondary prevention does not look very
This
promising.
increased risk of 20% and 38% with the polypill, was that relative to a control arm that was not on polypill? Because if these are high-risk people, if the increased risk is explained by high risk, then it will not be manifested in the
Yeah.
control arm.
I mean, there are small numbers, and you know that the risk estimates are quite unstable when you have such small numbers. So you have a total of 86 cardiovascular disease events. You had 39 all-cause mortality.
But the control arm is no therapy? The control arm is conventional therapy.
Conventional therapy,
But they take the same medication.
including all the medications
Yeah,
contained
they
in the
take the same
compound.
medication, this is just, one pill.
Yeah.
covering it all.
So the FDA is concerned that there is somehow a pharmacodynamic interaction between the individual components that is negating the cumulative or additional benefits of these therapies. That's why they want to do the definitive studies for regulatory approval, is to demonstrate that there is no pharmacodynamic and pharmacokinetic interaction, and that those can be done in crossover study designs, maybe 100 to 200 patients at the most. You don't need the 10,000 that are being enrolled in the HOPE study. All right, this is a question for Matt. So we have a 60-year-old male non-smoker with untreated hypertension. Systolic blood pressure is 145. He's diabetic. Total cholesterol is 200. H2 is 42. And has a pool cohort equation derived 10-year risk of 22%. Statin is recommended based on the guidelines, but his coronary calcium score is 0. Should we de-escalate therapy? And please elaborate, what do you mean by de-escalate? Should we not treat at all? Or should we lower the intensity of the statin dose?
60 years.
Yeah, so I mean, obviously, I never go against the overall recommendations for statin initiation or treatment, so I would probably put him on a statin. I would feel less compelled to put him on high-dose statin.
Okay. So you will
personally.
de-escalate, because the guidelines say if you're a diabetic and your total score is greater than 7.5, you can use a 7.5 as your threshold for intensive statin dose therapy versus moderate, even in the diabetic cohort.
Right.
All guidelines say intensive statin therapy. So you're saying that based on a coronary calcium score of 0, you're going to still treat, but you're going to reduce the dose.
I know I'm saying if we initiate dose, I don't know if I would personally initiate 80 of atorva in him.
Okay.
I'm not saying if he was on 80 and tolerating it well, I would recommend dropping it down. I would not de-escalate therapy. If the definition of de-escalate is he's on therapy, would I recommend that he take less? I would not de-escalate his therapy based on a 22% risk.
Okay.
If he's asking me, should I go on a statin, I would say, probably, he's diabetic, I would say yes, and I would not feel compelled to put him on a Torva 80.
Well, we just talked about the power of 0. I mean, it seems to me that you're not fully convinced about the power of 0.
No, I mean,
I think you've gone
I don't want to go against the guidelines. I mean, the guidelines, if you go against the guidelines, there is a medical legal risk. I don't think that's where we're trying to make decisions, though. I mean, I think 22% is a pretty high estimate to try to talk about de-escalation.
Well, let's say it's 12.
I mean, if he's close to 7.5, I would not put him on a statin
So
personally.
if
And
it's
I would wait another 5
12%,
years.
if it's 12%,
And you took away the diabetes.
Take away
No,
the
if
diet.
they're not diabetic, I would be very
Yeah.
comfortable.
Okay.
If you took away diabetes from that exact man, I would tell him if he wants to go with diet and exercise and retest his calcium score in 5 years, I would be very comfortable.
Yeah.
What is the recalibrated risk based on the coronary calcium score?
Well, now his risk goes down to way below
Therefore,
7.5%.
why would you put him
And the guidelines say if his calcium score is less than 300 or less than 75th percentile for age and gender, he is low risk.
Okay.
So he's
he's a
low
low-
risk according to the guidelines. But I would probably, because he's a diabetic, I would put him on some statin therapy personally.
Okay, let's help Matt.
Let's help Matt.
That's all right.
I'm helping you.
I'm good.
So using the MESA database and using the 22%
Right, it's too high risk
as
to
your
not treat.
pre-test probability, if you have a negative scan, your post-test probability drops to 8%.
Right. That's why we treat them still.
Okay, which is still above the treatment threshold.
And I put them
And
on
this is
treatment.
real world. Patients don't have a risk score of greater than 7.5. Patients have a risk score of 14, 16, 20, 30.
Right.
So these are real scenarios. So how would you do that? I mean, even with a calcium score of 0, you're still above the treatment threshold.
Right, so you would qualify for statin.
Right, so
therapy,
that's
and I
that's
put
the
him on
dilemma.
statin.
That's
Right.
the dilemma that.
But it's not, because you move him down from 20, and you're way below the threshold.
So here's what Martin is concerned about. What is a desirable false negative rate for a CSU of 0? Here you are in a situation with CSU of 0, and you still have.
Can I interrupt you?
Yes.
First of all, when you consider cardiovascular events, you're not only talking about coronary events, you're talking about stroke.
This is
And
CSU.
stroke. No,
Yeah, this is both. Both.
no, but in a pragmatic sense, in a hypertensive diabetic, even with a 0 coronary calcium score, you're still concerned about risk of
Right,
stroke.
absolutely.
I would image the carotid arteries as well. If both vascular events were negative, I would not be compelled to put them on the statin, because what would we be treating? What are we treating with 0 calcium and no carotid plaque?
I just think you maintain a medical legal liability if
No, but
he has an event. That's
but
the problem.
If you have 0 calcium score and 0 plaque in carotid circulation,
But-
what are we treating with this?
But PK, we have that residual argument of soft plaques in early, especially younger people, or B60.
But the prevalence of that nascent in the population is less than 5%.
So.
But that's significant for a total population. That would be a significant. I mean, definitely there is a legal risk. There's no
Yeah,
doubt,
in the ER,
right?
if you, when you use an ultrasensitive troponin, it has a false negative rate of under 1%. So if you have a low pretest likelihood of acute coronary syndrome and your troponin is negative, then you are on safe medical legal grounds to discharge that patient. Same applies to the D-dimer in a pulmonary embolism. Anything above 1% is considered to be too risky. So the question I had to this August minds out here is, what is a desirable false negative rate for a CAC of 0?
Well, you just answered whatever you can defend against the lawyer. No, I'm sorry.
But just, so your model here, he's still at 8%.
Yes.
So if he's at 8%, he's above 7.5% and deserves statin therapy. So we put him on statin therapy. But if you lower that 20 to 10, now you recalibrate, you're down at 4% event risk. And if you said, I have a person with 4% event risk, am I compelled to put him on a statin? And the answer is no. Based on the guidelines, based on medical legal, there is no compelling putting him on a statin. So if you can recalibrate below 7.5, that's the way the guidelines are written, you are safe to not treat.
Okay.
Now, whether you want to do that or not is an
No, I
individual
think
choice
let's
by
add to that.
physicians.
Let's add that. So do this and repeat it in 5 years and just continue that way. And the moment this surfaces above 0, you have a different story.
Okay. So this is a
Sanjay,
paper
you took
that's.
a very high risk subject,
Right.
you know. You're talking about a 60-plus man who's a smoker and has got type 2 diabetes.
Non-smoker.
Or hypertensive and
No, so
diabetic.
hypertensive and diabetic. Can you come down on your risk
I
category?
have a
Let's
spreadsheet for
take-
that. I can do it.
Let's take a 50-year-old female.
Let's do that.
Yeah, let's do that.
Okay.
But that's all right.
It's bargaining.
Yeah.
You tell me whatever you want.
Well, a 50-year-old female never hit 7.5%, so you don't have to treat them
Okay,
anyway.
50-year-old male.
You're safe.
50-year-old male.
All right, so if you want to say that the pretest probability in this patient is, let's say 12%, right?
Right.
Using these estimates, where do you go down?
So where does he end up with post-CAC in your curves there?
This is based on a CAC of greater than 100. I'm going to do this 288, 65, 2556, 2556, and 2978. Okay.
Good.
So you go from 12% This is the line 7. You go from 12% is the pretest likelihood. If you have a negative stress test, coronary calcium, it goes to 4%. So it
Right.
goes from 12 to 4%.
So I'd be very comfortable not treating that person with a 4% risk.
Right.
Because no guideline would advocate treatment in that person.
Well, we just showed you the exercise where even threshold of 4% is cost effective at about 80,000 per quality. So,
Wow, that's a different argument, right? That's, I mean, that's cost versus guideline treatment.
I was gonna ask, when you consider coronary calcium of 0, and then some of them had carotid plaque, what was the reclassification of risk? So that's kind of question
let me try to look that up.
that would be of great interest, because if the carotids were also negative, I bet the pretest likelihood would drop into lower than 80%, and below threshold for treatment. Or conversely, it might actually escalate the risk back higher.
Matt, the reason why I showed this example is that you said that in MESA, 1/3 of the individuals, diabetics, had a CAC of 0. You cannot automatically assume that all those patients, diabetic patients with a CAC score of 0, are all the same low risk.
No, absolutely.
And that is the value of showing this, that there will be individuals where it may be much higher, and therefore we have to be careful about that. This is an exercise that was published in JAMA. This is data based on the Framingham Offspring study and the 3rd generation study. And they wanted to see if you have high risk statin eligible, that's the term that they use, individuals, and you have a CSE score of 0, what is the event rate in those individuals? And what are the consequences of not treating those individuals? So number of subjects with predicted risk greater than 7.5 that are candidates for de-escalation by a CSE of 0 is about 306 out of 941. So it's roughly about 1/3 of the individuals. And the CVD event rate in subjects, in these subjects, is about 1.6%. If you were to not treat them and you were to shift them into the left lower column, then the CVD event rate in subjects with greater than 7.5 predicted risk and CSE of 0 would be 15 plus 5 divided by the denominator is roughly 1.1%, which is not different from the 1% that we are seeing in the lower left corner.
Right.
So, what they're saying is that a CSE score of 0 de-risks patients who have a predicted risk of greater than 7.5%. And a strategy of de-escalation has no material impact on the overall CVD risk. Thus, data suggesting the utility of CSE in de-escalating therapy, thereby mitigating the risk of overtreatment. To me, that is a greater opportunity than the other way around, which is, I'll come back to this. So we have another situation here. We have 60-year-old female non-smoker with a systolic blood pressure of 135, total cholesterol of 260, HDL of 50, LDL is 180, and the pooled cohort equation is about 5%, but her CSE is greater than 0, just greater than 0. We don't have the numbers. Should we escalate therapy? So when you do the same analysis, if you have a negative coronary calcium score, the post-test probability goes down to 2%. So all of us will agree that we will not treat this patient. If we use a coronary calcium score is 310, then these are the numbers, and we still wouldn't treat this patient. So, but the converse is also true, which is what the guidelines are concerned about. The guidelines are concerned about the risk of undertreatment. And they came up with these 5 biomarkers that they suggested, and I'll show you the data from family history and coronary calcium, which has already been presented earlier. So here's the Yeboah's paper. You've got patients, a CSE score of greater than 300 on the 75th percentile identifies 6.8% of subjects with less than 7.5 predicted risk category, the so-called statin ineligible cohort. By the way, the guidelines didn't say that less than 7.5% are not statin ineligible. I think that the floor on that number, we don't know. It's probably around 5% is what they're implying. but it could be even lower than 5%.
Yeah, the guidelines recommend that you have the conversation once you get to 5%.
Right.
So
No,
it's not-
less than 7.5.
Yeah, but they didn't say,
Conversations at 7.5.
no, they don't say that less than 7.5 are statin ineligible. They're saying that you're still
Conversation.
concerned, and if it's somewhere between 5 and 7.5, you can do these 5 additional tests that they recommended.
And have a conversation.
And have a conversation,
Say
for
that a
sure.
lot.
Yeah.
They say have a conversation in the 5 to
A lot.
7.5%.
Yes. So I'm saying, so it's really less than 7.5 is where the word conversation starts coming into play frequently in the guidelines. Not less than 5, it's less than 7.5. Because 5 to 7.5 conversation is part of the
Yes.
algorithm. That's
So,
all.
so based on this, we already had this discussion earlier in the morning, that about 264 people will be reclassified to a higher risk, about 7%. And the risk there is fourfold higher. The event rate is 13.2% versus 3.3%. So these data suggest the utility of CSE in escalating therapy, thereby mitigating the risk of under-treatment. To me, the most interesting finding in that Gervais paper is shown on this slide, which is where we use the family history. It's not premature coronary disease, any family coronary artery disease. And what do you find here? That it identifies about 5% of individuals, about 178 patients are reclassified to a higher risk. And the hazard ratio is actually a little numerically higher than the hazard ratio for coronary calcium. So these data suggest the utility of family history of CVD in escalating therapy, thereby mitigating the risk of under-treatment. So that speaks to your point. Why even bother with coronary calcium? Why not just do the family history? So I don't know, some of you may know who this guy Malcolm Gladwell is. And he just made a very profound statement that the future docs need more time, not technology. And I added that, future docs need more time to elicit history, not technology to elicit coronary artery calcium. So what are the arguments for or against using coronary artery calcium? The arguments in favor are that there is a high prevalence of coronary calcium score of 0, about 50%, including those that are deemed to be high risk. People with FRS greater than 20, about a fifth of them have calcium score of 0. People with more than 3 risk factors, about a third of them have calcium score of 0. It predicts excellent survival with low tenevariant rate, negative predictive values about 98%. And you can de-escalate therapy, and de-escalate therapy means one of 3 things. You could emphasize lifestyle over drugs, you can match the intensity of statin treatment, or you could forego repeated imaging, as some people had suggested. And therefore, it optimizes the resource allocation. The con are that the calcification rate is about 25% in 5 years. So the warranty period may be limited. I've heard numbers anywhere from 5 years to 15 years. Some people have argued that you may have to repeat the coronary calcification assessment at 5 years. It does not rule out non-calcified plaque. Luckily, the prevalence of non-calcified plaque is about 7%, and the contribution towards events may even be lower. Obviously, this strategy is not supported by guidelines, and we already touched about this, that the error of commission and the potential for medical legal liability is real. We should not ignore it, sweep it under the rug. So in my opinion, the quality and the quantity of evidence is insufficient to inform and guide clinical practice at the current time. And this, to me, is a ripe space to explore and see if we can maximize the utility of coronary calcification in de-escalating therapy and optimizing resource allocation. So I'm going to stop here. I'll be happy to take any questions.
Thank you.